This conference will now be recorded.
Okay, welcome, AnCanners everywhere. Those in the room, those listening to the recording. Today is April 1st, and this is Rick Davis, and I'm going to be leading the moderation tonight. And we have a couple of other official organizers, moderators on the call tonight, including Len Sierra and Peter Kafka. So we're going to move forward. We have one new gentleman who we welcome, as always, with open arms. And we will start with him momentarily. Just a quick thank you to our pharmaceutical sponsors who are Bayer, Johnson & Johnson, Novartis, Telix, Blue Earth Diagnostics, Foundation Medicine, and I think that's it right now. If I forgot somebody, you can remind me, but I think that's the current stable. I may not have mentioned the Sumitovant story or the Myovant story, but if I didn't, I will share it with you, which is that because they were a significant sponsor last year, but they Sumitovant acquired several companies, including Myovant and Eurovant and a couple of other companies. I think they always had an interest, Sumitomo Pharmaceutical. And there were 6 companies, and one of them had a drug that failed after they acquired it at the FDA, and that put them financially behind the 8 ball. I forget which drug it was. I've got it written down somewhere. It wasn't a prostate cancer drug. And so they now decided that they have to make cuts, and one of the cuts that they made was all of their patient advocacy efforts. So they got rid of the patient advocacy lady that we were working with and others, and they're not funding anything this year, which is a little disappointing. But they may come around, and they've basically passed the patient advocacy work off to the medical team. So, but we haven't heard anything from them, and not sure if we will. So that's why Myovant and Sumitovant is no longer on our list. Okay. Steve White. We have a few questions that we'll take you through just because we find that expedites the situation a little quicker, and then we'll drill down into the issues that concern you and give you time to ask us some questions. We'll probably take approximately 20 plus minutes to go through this, maybe 30. So it's not going to be that much of a rush. Is that okay with you? Steve White, is that
Yes, that's
okay
fine.
by you? Great. So how old are you?
Yes, that's fine. I think there's a little delay. So I'm 61.
Yep.
Can you hear me with the delay?
Yes. Okay. I'll try and allow for the delay. Where do you live?
In Raleigh, North Carolina.
Okay. Well, that's a good place because there's some good medical care for prostate cancer around there. And what year were you first diagnosed?
Diagnosed in 2015, and then I had my prostate removed in April of 2016.
Okay, hold on a minute before you. Okay, RP 2016. And when you were first diagnosed, do you recall what your Gleason score and your PSA level was?
So my PSA had gone just a bit above 4, maybe 5, and the Gleason score was 6. So they confirmed it with biopsy and then removed it pretty much straight away.
So your Gleason score was a 3+3? And I would warrant that you were not being treated at either Duke or North Carolina.
That's correct. I was seeing a doctor that was recommended by my general practitioner with a local urology group.
Yeah. Makes sense. So even at that young age, which is, I'm sure, why they responded so quickly, it's it's still somewhat questionable. Was the 3+3 confirmed in the post-pathology biopsy? Post-surgical pathology, excuse me.
I believe so. I believe so. What I mainly remember is they said that. Go ahead.
No, I didn't say anything. Keep talking.
So what I So what I mainly remember is they said that the tumor, I guess, was the size of an English pea, that it was completely contained within the prostate, and they said that they were pleased that they got it all, that none of it had left the prostate.
Okay. If you don't have your surgery report and your pathology, your post-pathology, it's worth reaching out and getting that because it could be important now. The surgical report will be with the urologist, and they should also have the post-surgical pathology. And since you're back with us, I assume we'll get to it momentarily, but there were some issues, and so you will need that information, and you should have that information if you don't have it right now. So I'm assuming that they did not do any scans. Did they do any scans before you had your radical prostatectomy? No. Which
No.
I would not have expected them to do because you didn't have a 4 in your number. You didn't have a Gleason 4 anywhere. Tell us what happened following 2016.
So my numbers were very good for several years, and then in May of 2022, it went up to 0.055, and then in December, it went up to 0.09. And so, and I'm going in for, I've just had the blood drawn, and I'm going to be going back into my urologist on Wednesday to find out the new score, which I kind of assume that the numbers will probably go up. And I was recommended by a friend of mine who has got a tremendous amount of help from this group. And let me just say here, I think this is a wonderful thing you're all doing, and I completely appreciate it. So my main question is just going into this meeting, he talked about medical oncologists and genetic testing. I listened to one or two of the recordings from, I guess it was last week, and about scans and that kind of thing. And so really what I would love to get your insight on, it may not take a lot of time, but I don't know what questions to ask. So when I go in, if the number has gone up, then, is that the, to be asking what questions? So that's why I'm here. And like I say, again, I'll just say how grateful I am for all of you to be here too.
It's our pleasure. That's why we're here. So just to be clear, you were pretty much undetectable until May of 22, when you got a reading of 0.055, let's say 0.6. And then the next reading you got after that was in December of 23, which was 0.09. And now you're waiting on the reading that you just did. Is that correct?
Correct. That's right.
Okay. So the first thing, like I say, is it'd be real interesting to know what your pathology was, your post-operative pathology, because what they do at that point is they slice up the whole prostate, and they look at every slice, and they come up with a final Gleason score. And it would be unusual, very unusual, if you were a 3+3. And so it's worth knowing if your final score was a 3+3. But that will come out of this, and will help you read that final pathology score. The $64,000 question right now is what the next reading is going to be. I don't have to tell you that. I'm assuming you don't know, and they haven't sent it to you on the portal, and they're going to give it to you in your meeting tomorrow. Is that right? Yeah.
On Wednesday, yes, that's the expectation.
On Wednesday. Well, if it appears that there is recurrence, because we don't really know yet, and I don't want to assume, because there could be other things, but I'm not sure what, but there could be other things. But assuming there is some recurrence, the only question I would ask your urologist, and is this the same urologist that did the radical prostatectomy? Yeah. Is, please, can I have the surgical report?
Yes.
And please, can I have my post-pathology and any other notes you got about me? And then we will redirect you, most likely, to Duke, if you can get to Duke, if you're covered at Duke, and we'll give you one or two names there to ask for who know us, and we'll get you over to somebody who's going to make sure you get the best possible treatment. The scan that you want to be doing, and I would have this scan ordered by your genitourinary medical oncologist, your GU medical oncologist, is the PSMA scan, the PSMA PET scan, and there's enough recent research to suggest that you might be looking for something as low as a PSA of 0.2. So given your history and given that you're moving over, if your new medical oncologist says, let's wait a tad, don't be surprised. But we typically have not really looked too hard at less than 0.5, but some very good recent research that came out, and I don't know if Len has it. If not, I've got it. I can find it in a moment from Dr. D'Amico and Dr. Carroll and others. Now says maybe we should be looking a little earlier. Maybe we should be looking even under 0.2. And we'll put that link in the chat window for you. As far as the genetic testing and genomic testing is concerned, at this point, one thing you can do right away is you can get a genetic test or a germline test, which will essentially tell you if you have any inherited cancer. Do you have any cancer in your family?
No, not in my blood relatives. No.
Okay, so it's still worth doing that test, and I'm going to put the link in here for you right now. All you got to do is go ahead.
So I had one question back to the, as far as the likely redirecting me. I don't know if I'm covered at Duke. Because of my wife's situation, I do know that I'm covered over at UNC in Chapel Hill. Is that
right?
Is there a marked difference between the people at the two, or should I investigate Duke?
Here at AnCan, we do think so. We think that Duke has a much better staff for prostate cancer than does UNC. There are a couple of docs at UNC that I think we can come up with. I just saw somebody from UNC doing a talk. But if you can get to Duke, I'd strongly recommend it. If it were me, I'd bust my chops to try and get to Duke if I could. But if you cannot get to Duke, then come back to us and we'll give you some names at UNC. I mean, I can call my Duke docs and ask them who they would see. That's what we'll do. I mean, because the people that I know of at Duke or I've seen at UNC, I sort of don't really know much about them. So what I would rather do is ask the docs who we have a good relationship with at Duke and say, look, the patient cannot go to, he's not covered at UNC, at Duke, who would you recommend? And that's the way we would go about doing it, and we'll get you a name. But if you are covered at Duke, then I would strongly recommend you see Dan George. He's one of the best docs in this area in the country, and I'll give you there is some information in the chat window already for you. The chat window, if you're not certain, it's those two little squares in the top right at the top next to the number 31. And if you click that, there's information in there. You don't have to copy it down. Just click on those links. They'll open in your browser and you can take a note of them later. So the first piece of information, thank you, Len, is the article from Medscape Today that I was referring to. And I actually have a reference to the article that appeared in ASCO, I think it is. I'll try and get that in for you as well in a minute. The second article, the second link is to the PROMISE study, which is a free germline genetic test. Just follow the instructions. When you get to that link, they'll send you a kit. You'll take a mouth swab and send it back to them, and then they will send you the results. And if necessary, they will also make arrangements for a genetic counselor. It's all free. It's actually part of a clinical trial being run by Hopkins and Fred Hutch in Seattle. So it's all above board. They use color. So I'm going to throw it open at this point to anyone else in the group who'd like to talk to you, and I'll try and get a couple of these links into the chat window for you. Anybody like to say something to Steve? Quiet group. Len, thank you.
Welcome to the group, Steve. You've had 2 PSA rises since your radical prostatectomy. Is that right? Just 2? Okay, so I thought we were defining PSA increases as 3 consecutive.
Well, that's why I say we're very interested to see what happens.
Oh,
But
okay.
He's going back on Wednesday, and we're talking to him on the basis that he's got an increase. As I said before, if it goes down, then it would be a bit of a puzzle because I don't know where it would come from, but there's something going on. So let's see what happens here. My feeling is that if it does go down, I'd still switch docs. And I'd get another opinion probably from a GU medical oncologist. What would you do, Len? If it went down this time, what would you do?
Yeah, he should probably go to a GU medical oncologist just for confirmation that there is or isn't any further treatment needed at this time. With a Gleason 6 that was very small to begin with, I think it's more likely, of course, this is just speculation, but it would seem more probable that the source of any rising PSA might be a few healthy prostate cancer cells left behind after the surgery. But just an opinion, no evidence.
Yeah, but why would they have taken 6 years or 7 years to show up, Len?
Might have been a very tiny amount of cells. I don't know.
Yeah,
but
it's strange.
Yeah.
Peter Kafka.
I just want to make sure I heard right. So we're still talking about under 0.1, right? The PSA is 0.1 0.06. Is that right?
9. 9.
0.09. So it's still under 0.1.
Yep.
Okay. So the chances of a scan showing up anything are pretty slim, probably.
Well, you know, D'Amico and co say that you should start looking at zero, maybe just a tad under 0.2. So
Right. So it's not at that point. But and even if recurrence at this point most likely would be someplace in the prostate bed. Now,
yep,
whether the scan would pick that up or whether an MRI, has he had an MRI yet?
nothing. Has had
Nothing.
nothing.
Yeah, I'd think an MRI, maybe an
Oh,
MRI would be first in order, but that's my thought.
Well, you know, I think, like I said before, the obviously the first step is to see where this comes in. Come back with us next week, and Peter will be in the chair next week, and we'll bat it around a little bit, and we'll try and give you some good direction. I think if it has gone up, that moving your care to a center of excellence is going to be the most likely to find where the source is. That's my gut feel.
Rick, that D'Amico study was looked at people who had at least one high risk factor, and Steve doesn't have any high risk factor.
Oh, right. Yeah, good point.
So
Good pickup.
not sure it applies to him.
That is a good pickup, but you know, I think that's why if you don't have a high risk factor, that's why you need a good medical oncologist to make the calls. I'm not sure I would want a local guy, especially one who rushed you into a radical prostatectomy, to be doing that. You know, that's still, I'm not saying a radical prostatectomy is a bad call for somebody who's 52 or 53, whatever you were, and it may have been the right call, but I'm not sure I would have rushed you into that. And if you would have come into us at that point, we would have had you getting more opinions. So, you know, this guy, the mindset of this same doc, it doesn't sit well with us. It might be the right decision, but that's not how we feel prostate cancer should be treated, if that's a reasonable statement. So I'm trying to, here we go. I'm going to put this article we're talking about. There's a review of it from MedPage Today that Len put in a link to, and I'll put the actual link to the article which appeared in ASCO publications. I just put it in, so underneath Dan George. So you'll be able to pull that up, and you can noodle it and go from there. Okay. Do we have your email address? Have you signed up for a reminder? You have. Good. Okay. Excellent.
yes.
Anybody? Excellent. Anybody else have any thoughts or words of advice, support for Steve before we move on?
I'm just glad that he's in the direction of what looks like better care.
Say that again, Jimmy. You're just glad?
I'm just glad that he seems to be in the direction of better care.
Yes. Yeah. 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 So that's
It's interesting to see that it's interesting to hear that, I guess, your suspicion, it sounds like, if that's the right word, that having it taken out was not the right thing. But that we've already, that's water under the bridge at this point.
water under the bridge.
So, now we go from here, right?
Right. Now, I don't want to say it wasn't the right thing, because when somebody has prostate cancer at age 51 or 52, it's managed very differently. What I do think is it was all too quick in how it happened, that you didn't get any, well, I'm assuming you didn't get any other opinions. You didn't say that. I shouldn't have assumed it. Did you get any? And that they were looking to take it out. I mean, it probably was the right decision to take it out, but we like to see the urologists, especially with younger men, go through all the issues and make sure they've thought it through, because you know what the side effects are, and I don't know how well they covered that, and I don't know how well your recovery has been, and if you've had issues, but we don't like to see people getting rushed into surgery with a 3+3. Now, as it turns out, if in fact you do have recurrence, it was a good move, because you would have needed treatment anyway, but it's really more the fashion that it happened, because you can't now, and that's why that post-operative pathology is kind of important. We'd like to know what they found there, and you probably wouldn't mind knowing at this point in time what else they found, right? So, but at the same
That's right.
same time,
That's right. We'll definitely.
A good solid urological oncologist surgeon would have reviewed what they found for you. So, that's sort of just another question mark. Okay. So next week we meet next week we meet on Tuesdays. You'll get the reminder. It's going to be Tuesday at 6:00 Eastern time. Second and fourth Tuesdays, first and third Mondays at 8:00 Eastern. Oh, Peter, you had your hand up again?
No, I never took it down.
Oh, you never took it down. Okay. Bill Franklin, did you want to say anything to, you were diagnosed at a very young age?
Yeah, I was diagnosed at 51 also, Steve, and mine was a little more aggressive than yours. It was a 7 at diagnosis, and I had a higher PSA. And then post, as Rick was talking about, so post prostatectomy, they biopsied the prostate and the tumor, and they upgraded it. They said I had an 8, a 4+4. So, and then I had a recurrence almost immediately after surgery. So a little bit different, but when you're younger, as Rick said, when you're younger, they look at it differently. And you don't feel young at 51, but look around you, look at these guys. I was young at 51. Now I'm not young anymore.
And we do have a group for younger men with stage 3 and stage 4, which if there is recurrence, you'd be eligible for that. And even though you're 61, you're welcome to join. And that's a group where we really talk less about the treatment issues and more about some of the other issues that come along. So but I don't want to jump the gun yet. Let's see how you do. And if something comes up on Wednesday and you're feeling out of sorts, feel free to reach out. So that's it. Okay, gents. I am going to move along, and the first person on my list today who was here when I turned on the app, the room, is Joe Blanchette. So we'll start with you, Joe.
All right, a few things as an update. In the last couple of weeks, I reported to you that my pulse had gone down to 46, but my PCBP took my Tylenol from 15 mgs to 25 mgs, and now my PSA slowly has come up back to 56, and I've been at 58 for the past 5-10 years. So hopefully I'll get back to 58 in the next week or so.
I'm sorry. What is that that's come back to 58?
My pulse had gone down to 46.
Oh, your pulse. Okay.
Also, I taken a blood test on 31 January. Then a month later, also Dr. E required another blood test a month later, and it's because all my all my tests were sort of screwed up. Never seen so much red on my blood test before, including my red blood cells, my white blood cells, and my platelets. And so I went to 3 PCPs, one in the Veterans Administration, two on civilians on the outside, and they've all 3 said, "Oh, it's your darolutamide causing this." I told Dr. E, I says, is my darolutamide dose too great for me? She says, no, stay with the darolutamide, come off the atenolol. So that was her opinion. She writes, when I write to her, she writes little cryptic notes, and you have to decipher the notes as to what she means, but that's what she meant. So, so then I call my radiation oncologist. I said, is there anything that you did back in November, December when I had 4 sessions of SBRT with you to cause this? She said, no, I don't believe so. So then I said, the heck with this, I got to see a blood doctor. So I went to a hematologist a week ago on Monday, and that was Dr. Josh Allen of the Nova Shar Center in Fairfax, Virginia. And he says, oh, it definitely is your SBRT. He says, bone marrow gets attacked badly when you radiate long bones like your legs and arms and spine, and you had 4 treatments to your spine, so that's what's causing it. He says, by the way, I wouldn't be concerned about your white blood count because your neutrophils went up to the normal range in March. And he said the neutrophils is what matters in order for you not to catch pneumonia or other exotic diseases. He says, as long as your neutrophils are in the normal range, I'm not concerned about your white blood cells. So that was an opinion that I had no idea about, as he sort of educated me. I know you guys have talked about this in here many, many times. There's a lot of you, because of the treatments you've had, you've been low on white blood cells and so on, and red blood cells and platelets. But so anyway, Dr. E is not concerned. Dr. Josh Allen is not concerned, and they're in the cancer business. So I'm hoping that they're correct, and my blood test will keep on improving. I did take it.
So before you go on, Josh Allen is actually a GU medical oncologist. He's not a general medical oncologist. He is one of Richard Craman's doctors,
Right.
who's treating him for the what do they call it? Spongy, whatever they call it, spongy, foamy cell, spongy cell, or whatever it is.
Right. Same guy. Yep. And he's a hematologist too, of course. So,
Right.
I also took the Veterans Administration gave me an FDG PET scan, my second one in 7 months, and it basically mirrored the one I took back last August. And it did have mediastinum lymph nodes that lit up again, but they hadn't grown since last time. And my doctors so far have not been concerned about them. Also, the mediastinum lymph nodes did not show up in February, this past February, on both my PSMA PET scan and my whole body MRI that Dr. E gave me in Houston. So it seems that the FDG PET is concordant with those two other scans, and that I still don't have any prostate cancer showing at all on any of those three scans. Of course, I know I still have it, but they're microscopic or they're asleep. That's the end of my update.
How anxious do you feel?
A lot less, especially since I saw Josh Allen. He really educated me, and I was concerned about my white blood count. But he educated me so that I wasn't, he says, I don't even want to give you a blood test. He says, how often does Dr. E give you a blood test? I says, every 3 months. He says, that's fine. Just keep on doing them. And so, I was impressed by that.
Okay.
Plus, I feel okay. I'm feeling okay.
Good. Anybody have any comments? Any of you who have wrestled with strange patterns in your total blood counts? Somebody's who? Dr. Jeff. Yes, I was thinking of you, Dr. Jeff. Go ahead, please.
How low is your white count?
It used to be 2.4. It's sitting now at 2.7 as of a month ago.
And do you know the percentage of polys, neutrophils?
Yeah, hang on. I have the report around my computer here. Hang on. Okay, I have it here. Let me see if I can find the neutrophils here real quick. Neutrophils. Yeah, lymphocytes, neutrophils. It's 42.4. Does that make sense to you?
Or neutrophils or lymphocytes?
Neutrophils. Lymphocytes are also they're at 42.2. I'm sorry, the lymphocytes at 42.2, the neutrophils, as I said, are at 42.4.
So they're low,
Yes.
and I would avoid crowds.
Okay. I've been doing that anyway, but yes, I appreciate that.
Gary.
For a long time since my radiation in 2021, my neutrophils are way high and my lymphocytes are low. I was going to say to Dr. Jeff, so I've read in several places that a very high neutrophil to lymphocyte ratio can be a negative sign in your prognosis, but none of my doctors seem concerned about it. and they say the white count is probably the result of the radiation. And haven't suggested doing anything about it or worrying too much about it.
Were you on steroids with that ratio?
Yes, I was on
Yes.
steroids for 3 years, two and a
So
half years.
most likely it's the steroids.
Huh. Yeah, those steroids did a number on me. So those will knock down the white count.
It'll change your, raise your polys and lower your lymphs.
Thank you.
Yeah, also as a point of clarification, I haven't found the report yet, but the report I was reading to you from was the January report, the first report, and that's when the neutrophils were at the lowest point. I don't know what my neutrophil count is on the February test, so I'll find it and get back to you, but I don't want to hold up the room.
Okay.
All I know is,
Okay.
yeah.
Okay. Anybody have anything else they want to contribute on blood counts post treatments before we move on? Okay. Mark Valens, your turn.
I just see if anybody else has heard of this. I saw the PCRI conference. This was on Saturday, and Dr. Schultz raised something I hadn't heard before. He said he had patients who had been in remission, and then they got a PSMA showed like 1 or maybe 2 Mets when it recurred, and they zapped them with radiation. And then his patient said, "I don't want to go back on ADT," and they didn't. And year, 2 years later, they're doing just fine. And he said that there's indications that where you just have 1 or 2 Mets and you zap them, maybe you don't have to go back on ADT. I had never heard that before. I was wondering if anybody's got any comments about that.
So, there's sort of a new body of literature coming out, which is called metastatic treatment. I saw the phrase used for the first time late last year. And my understanding of this metastatic treatment is what happens is how they treat oligometastatic men. So if you have very few lesions, there are options to treat. And one of the options that's being put forward is just to zap the lesions and not to put people immediately onto ADT, which I think is what you're talking about. So it's not, what's being suggested is not new. Maybe 5 years ago and certainly 10 years ago, they probably would have given you at least an LHRH drug, but there seems to be more patients right now. And I think one of the reasons for that is because the scanning is better, so that we can follow it and we can find out where, if somebody is going off the rails, without throwing them all in to the deep end with ADT and maybe even a second line anti-androgen. There's a question as to whether you even use a second line anti-androgen when people have less than four Mets, and just a little bit. I think some docs will and some docs will not. Let's see what people have to say on this. Peter, first of all, and then Joel.
Yeah, Dr. I've been with Schultz and Company for 10 years, and I had a consultation with him several months ago, and this topic came up, and he set up an appointment for me with Michael Steinberg, who's the head of radiation at UCLA, who's a good friend of his. And because my last scan showed a decrease in my MET activity, but it's in an odd place for me. So Dr. Steinberg felt that for me, this is radiation was not appropriate because of where the location of my Mets are and other factors in my previous treatments might exacerbate some of my intestinal issues. So anyway, but that I am familiar with that idea. I think Dr. Schultz is, he's thinks outside the box, the proverbial box, and he was willing to explore that, and he set it up for me. And when I met with Dr. Steinberg said he would go back to Dr. Schultz and tell him that in this situation, it probably wasn't appropriate for me. So I'm aware of it.
Joel.
Yes. The description that Mark Balance just gave is basically my situation also. I just had a prostatectomy. Then 9 years later, PSA went up, and I was given SBRT to my left iliac bone and right occipital condyle bone. A couple of years later, the PSA went up again. And even though my PSMA PET scan and my FDG PET scan and my whole body MRI said that I had no cancer, some smart radiologist that sits with Dr. E figured out that I had dormant prostate cancer on 4 of my vertebrae. They then radiated those 4 vertebrae November and December last year. So yes, they do that actively now, from at least from what my radiation oncologist tells me.
So, I think one of the big issues, and I don't know if Dr. Schultz explained this in the PCRI virtual conference, is probably the history of the patient. If you had somebody that had a 4+5, for example, and they had radiation and 2 years of hormone therapy, and then they stopped, and then it comes back, and you just see a couple of little things. I'm not sure that somebody like that would be a good candidate just to zap if they have a history of aggressive disease. If it was somebody who had a much less aggressive, as Len said earlier on, not many risk factors, you might treat them differently. So I don't think it's one size fits all. And the reason I'm saying it is because it's not good for people to walk away or listen to this broadcast and walk away and think, oh, well, that's great, because if I have a little lesion, they'll just zap it, and then I don't have to worry for another 2 years. It really depends. This is why, we go back to the conversation with Steve White. You got to have a really good medical oncologist on your team if you've got untoward issues. It may be that Steve doesn't have to do anything. He can watch this for the longest time. But maybe a doc like Dan George is going to say, you know what, I think we should get this early based on what I've seen. And maybe we can really nail it. So there isn't, every situation is a little bit different.
Well, that may explain it. Thanks, Rick, because neither Dr. Borno nor Dr. Roach even mentioned this possibility. But my recurrence was one single met on the pelvis, which they irradiated, but I was never offered this opportunity. And the second time around on ADT is even less fun than the first time. But it could well be that they just didn't bring it up because I was 5+4, and it was not appropriate for me. So
Yeah.
thanks.
I mean, did Dr. Schultz give any history on these people or not?
No.
I mean, that's what I would suggest. And, both Halaborno and Mac Roach are open enough to questions, although probably if you ask Mac, you'll get a reply in less than 2 lines. But, yeah, I mean, you should ask them. But my guess is if you were a 5+4 originally, you're probably not a candidate. I mean, what would Len? What would you say on this subject?
Well, there have been studies showing that what you're talking about is MDT, metastasis directed therapy, where they've shown that if you have oligometastases less than 5 and you radiate them plus ADT, that is superior to 6 months of ADT. That is superior to ADT alone. There was I think it was a phase 2 trial called Extend, EXTEND, and it was probably high risk. I don't recall, but I remember Rick Alan Adele did a whole long, well-documented treatment of this a couple of years ago. And sometimes with Alan, he puts in so many contradictory studies. You're not sure what his final opinion is, but at least I had the impression that it's a legitimate treatment. MDT, metastasis directed therapy. It may very well delay treatment. Well, it may delay the next treatment, whatever it is.
Mm-hmm.
Yeah. Okay, thanks, Keith.
Anyone else before we move on?
Rick, just an add-on for Dr. Jeff. My neutrophils on the last blood test was 57.5, quite a bit better than before.
Okay, well, let's keep.
I've got one comment on that. Is if your scan, and this happens with some of the guys after treatments, if your scan is showing a retreat in your mets, less activity, decrease in activity, it might well be a way to go to facilitate that if things are on the decline. I don't know.
Again, I would say you've really got to look at the history of the person. I mean, I think a guy that's a 5+4, you might treat very differently to a guy who's a 4+3 originally. I think that's the issue. That's where this becomes an art rather than a science. And some of our GU medical oncologists are more like artists than scientists, such as Dr. Schultz.
Well, that's true. That's true for all of us on this call. I mean, each one of us is pretty much an individual. We're not just items on a shelf anymore.
Yes and no. I mean, I think what I'm trying to bring out here is that even if you are similar, even if you think you might be similar to somebody else, you've really got to look at their history versus your history. And if your history and their history are very comparable, then by all means take what they're doing. But yeah, I mean, yes, you're definitely a unicorn, Peter, in the way that your disease has acted, and as are some of the other guys, but not everybody. There are guys who have similar situations here. So, all right, we are going to move along to Dr. Bob.
So last time I was here, I had gotten a bone biopsy hoping to get some sequencing, and they were not able to get enough cells to do that. Since then, I was alerted to a clinical trial for ARV-766, which is a AR degrader.
Yep.
It's a phase 2, and they are only accepting men who have one of 4 AR mutations. Back in October, I had a liquid biopsy. It showed I had one of them. So I went to Fox Chase, not this past Wednesday, the Wednesday before, and they're like, you're a good candidate, but we have to do a new liquid biopsy. Well, the new one came back. I have 2 out of the 4 mutations. So things are moving quick, which is good because I've been in a lot of pain. I spent 4.5 hours on Friday at Fox Chase getting all the scans and blood work and EKGs. And so this coming Wednesday, I'll be starting on ARV-766. It's an oral med. I'll be randomized either 100 or 300 milligrams once a day. And I'm hoping for the best because things are starting to take a turn for the worse. My PSA in the last month went from 79 to last week 118. My red count is getting lower. My hemoglobin's getting lower, though my white count and my platelets are still fine. But having more pain as the cancer is growing in my bones, and everything I have is in bone. So at Fox Chase, it's Daniel Geinesman, who I know you guys know, and yeah, that's my hope that it will destroying the AR receptor will put a stop or at least slow things down.
So we also know Arvinas pretty well, and they, through Len, it was Len's introduction originally, and I've built a bit of a relationship with them, and we're planning on doing a webinar with them later in the year, probably with Atish Chowdhury, to talk about their clinical trials and what's going on. Dr. Atish is at Dana-Farber, and we have some very good history with him too. He's a really good guy. So I know the lady who's in charge of all of the recruiting there, and actually helped her out because her dad had some issues, which I think they've resolved. What, not prostate cancer, something else. And I know the lady who's sort of in charge of the whole group. She's really nice. So if there's anything that you need with respect to Arvinas, I can reach out to them. We have a good relationship with them.
Yeah, I mean, from what I've heard, all my lab work, all my scans, my EKG, nothing stands out that would preclude getting, and I have an appointment Wednesday to get started, so.
Okay, so, and I'm pretty sure I'd have to go back and look at my notes. I think there's somewhere on my desk from GU ASCO, but I'm pretty sure it was 766 that they wanted us to that they want to talk to us about. So we'll already be in an expert because they've got a couple of things that they've got a couple of drugs that they're working on right now. I know.
Yeah, what happened, it seems the phase 1 men who had one of 4 mutations, which apparently is about 20%, did better. So now for phase 2, they're only accepting men with, these mutations for phase 2.
Mm-hmm.
Bob, is this an infusion or a pill? What is this?
Oral med.
All meds.
Yeah, oral. It's a pill. I'll either be randomized to 100 milligrams once a day or 300 once a day.
Okay, so it's once a day. Okay.
Side effects don't seem to be too bad from phase 1, nausea, fatigue. They want to keep check on the heart. I mean, they're doing EKGs before I take the pill. An hour later, EKGs again. I come back the next day for labs and EKGs. So
the pill is administered at Fox Chase. You don't do it at home.
well, no, just the first pill.
I see.
Yeah, I won't have to go every single day. After the first day, then it's once a week. I go to Fox Chase for a month. If everything's good, it's every other week for the next 2 months, and so on. They just want me.
Who put you onto? Who was it who put you onto this, Dr. Bob?
Well, my oncologist at Penn suggested Penn's running a AR degrader trial, and then it was actually Dr. Shivelman at Cancer Commons who made the connection with that I have this mutation, which is what they're looking for the ARV. And I figured this made sense. Fox Chase has been really good about communication and getting me in. I mean, I sent a message through the portal to both my doc and Dr. Geinesman. Geinesman got back to me the same day. I didn't hear from my doc for 4 days. I did the liquid biopsy Thursday. The results came in. Next day, I was in for all the scans. So, I figure with the mutation and new set of eyes can't hurt.
Excellent. Well, Geinesman knows AnCan pretty well. And we've got I think we've got 2 or 3 of our people who are he currently treats, but historically he knows us pretty well as well for various reasons. So, and he's a good dog. He's a good son.
I know a few people who see him and they've all been very happy. And it's not that it matters, but it's a totally different feel than at Penn. It's not so clinical. Not that that matters, but I just thought this gave me my best chance as opposed to going with a study that are accepting anyone.
Well, the big issue in my mind, Bob, with you and we just have to keep it on our radar, and I think it's even though it's not part of the trial, talking about it with Geinesman, is to make sure the cancer isn't morphing and changing into a neuroendocrine type of cancer, and we got to be looking out for that all the time.
Yeah, no, I know. I did the bone biopsy was looked at Penn, and they didn't find any neuroendocrine differentiation. I haven't been on any second generation hormone therapy for over a year.
Mm-hmm.
So, what's driving my cancer is seems like the mutation of the AR receptor.
Yeah. I mean, the only thing I just want to point out, and hopefully they're right, and hopefully then this is going to work well. But with neuroendocrine cancer, it can be in one place but not in another. It's not consistent across the body. So if they don't find it in one biopsy, then doesn't mean it isn't somewhere else. Now, you're more likely to find a clue from doing a liquid biopsy
Right.
because
And I had that, and there was nothing that suggested.
okay,
It was foundation medicine they did.
okay. Len,
Yeah, Bob, whatever happened to that functional precision medicine approach that I think you talked about last time you were on with us?
Yeah, I'm waiting to hear back from them. The last thing was it looks like we have enough cells, but I'm not banking on that. Um, I got to go with something because my
Yep,
PSA is rising, my scans are getting worse, I'm having
sure.
more pain, my red count, hemoglobin's slowly going down because everything's in the bone. My plan
Yep.
B is if this doesn't work is probably chemo. I hope I don't get to that point, but you know, uh, as we all know, it's good to look at where you are and where you might be for the next step.
That functional approach, if I understood it correctly or remember it correctly, they just take your cells and they keep throwing stuff at it in the lab and see what happens, right? So
Yeah, and it's
they
somewhat
don't come back to you with any treatment until they say, hey, we found something that seems to be killing your cancer cells, right?
yeah. I mean, and it's somewhat controversial because you're taking the cells out of the body, and that changes
Yeah,
things. So I
sure.
mean, certainly if they came up with something, if this doesn't work and they come back, cabazitaxel would be better than docetaxel, fine. But like I said, this trial came up and it seemed like it made sense. And I'm hoping for the best.
Yeah, good luck.
Thanks.
We
ju-
are
just
too. We are too hoping for the best.
Thank you.
just as some encouragement, if you do need to look at the cabazitaxel, is that a lot of our guys have not a lot, but a number of them have tolerated it exceptionally well.
No, I know it's not too bad. At Fox Chase, one of their patients has the same two mutations. He was on phase one. He's now shifted to phase two, and according to the nurse, clinical trial nurse, he's done very well. So, I mean, that's obviously just one person, but the fact that they're looking for results, and the fact that they are limiting it to at most 20% of the population with people with those mutations suggests to me that you know I got a better shot than some AR degrader that's looking at everybody.
How common are these AR mutations that they're focused on?
I was told that having one, there's four of them. They're looking at about 20% of men with metastatic castrate resistant have one or more of these.
Okay. Okay.
So it's not uncommon, but it's not real common.
Right. Okay. Anybody have any questions for Dr. Bob?
Okay. Thanks all. I'll keep you up to date.
Gary Peters.
Hi, Bob. I was just curious, where did they? When was this particular mutation found? Have you known of this for a long time, or is it recent?
So it was picked up in October on a liquid biopsy, but at the time the AR, the trial was a phase one, so there was no restrictions. And then it's just pretty recent when they switched to phase two that they limited that. And then when I went to Fox Chase, they're like, we need a newer liquid biopsy, which they did. And like I said, it came back. I had 2 out of the 4.
And were these new? Like when you first had genetic testing, did these show up?
No, these are, I had AR amplification, but not these they're point mutations in the androgen receptor. So, my original biopsy was almost 2 years ago. So a lot has changed in that amount of time.
So
So
these mutations
just
have
to be
afforded you.
clear, just to be clear on these mutations, these are androgen receptor mutations, and we see them on these somatic analyses, and they usually says AR and a bunch of letters or numbers after them. So these are specifically androgen receptor mutations that we're talking about. Go ahead, Gary.
No, I was just going to say, so these mutations have afforded you a treatment opportunity that you would not have otherwise had.
No, you're right. It also has afforded me, failing everything in sight so far. My understanding is these mutations don't let AR blockers work. So,
Yeah.
abiraterone, enzalutamide, all those are ineffective because of the mutations. Potentially even, Lupron, Eligard, may be ineffective, but I'm certainly not stopping that.
And when do you take your first dose?
Wednesday.
Yeah, good luck.
Okay. We're all thinking of you and hoping for the best. And like I say, if you need anything with our Venus, we know the folks there, and we like them and they like us.
Appreciate it.
So, it's good. And I'll probably let them know that we have an AnCan who's going on this ARV-766 trial too. So, okay. Next on my list is Richard Fisk. Mr. Fisk? Can't hear you. No, it looks like your mic might not be working. It was working before because we heard you for sure. You talked to us, but now we don't hear you.
Any better?
Yeah, for a second. No, there's obviously a bad connection somewhere because we got you loud and clear for like less than half a second. So something isn't plugged in and functioning right.
Okay. Can you?
Yes.
Is it
Yes.
working? Huzzah.
Yes.
Okay. I wanted to say that my my concerns are rather trivial after listening to Bob.
No one's concerns are trivial in this group. Everybody is valid, please.
Last time was my first time. I had mentioned genetic testing. The genetic testing has come back, and it's 0 for 48. So there were no mutations.
Okay. So no mutations. And was that where was that test from?
National Military Medical Center, Walter Reed.
Okay. Okay. All right. Well, yes, but sorry. who did the test? I don't mean the hospital you got it at. Who did the test?
I don't know the name of the outfit. I will find that out.
Okay, it's good to know. And that was a germline test, correct? For inherited mutations.
Correct.
Okay. All right. Well,
That's
glad to hear that.
that's the first item. The second is radiation prostatitis. I have started bleeding and bleeding with my stool, and I've just started on sucralfate and Miralax to try and cover the lesion and give it a chance to heal.
Mm-hmm.
Do you find that in this kind of prostatitis sore that they do heal over time?
So it's actually called proctitis, not prostatitis. Proctitis.
Okay. Sorry. Thank you.
I'm going to turn it over to my resident expert, even though I have been a sufferer, Len Sierra, because he suffered and he's had treatment. So Len, and plus he's familiar with the drugs.
Yeah, I'm a reluctant expert on this. Not really an expert, but I tried steroidal suppositories. They didn't work. I tried sucralfate. It didn't work for me. Doesn't mean it won't work for you. And then I went to argon plasma treatment, which is like having a colonoscopy and they cauterize the blood vessels in your colon.
That was
actually in the rectum.
That was an option that was looked at in my Flex Sig a couple of weeks ago, and the GI doc is going to give the sucralate 8 weeks, and if there's 10 weeks, and if there's no joy, then the next step is the laser. There's concern about perforation.
Right, but if it's done by a skilled GI doc, you should be fine.
Okay, that's.
Yeah.
Go ahead.
Where do you live?
Alexandria, Virginia, Washington.
Okay.
Also, going along with this is my hemorrhoids are really acting up, and I'm getting fresh blood a lot, to the point where I have to wear Depends. And I'm trying not to strain. I'm using Preparation H. Is there anything else I should be doing?
That's something I didn't have, so I can't advise you there.
Okay.
Although I can tell you this much, the argon plasma treatment, I had 2 treatments because they want to go slow, like you say. They want to make sure they're not going to perforate your colon. And so the first time he used, let's say, a lower intensity, and it helped just a little bit, not that much. And then another 2 months later, I had a second treatment, and that cleared up about, I would say, 90% of the bleeding. I never had pain, by the way. I don't know if you had any
I have
pain.
no pain.
Okay. However, he said you'll still get some blood spotting because his exact words were, in the anus, he says, I can't hit that with the argon plasma. If I did, you wouldn't like me very much. And what he meant by that was you can wind up with chronic diarrhea. So that's why it's important to make sure you have a doctor who's done this many times and he knows, the caveats, he knows the things to avoid doing.
Well, in the Flex Sig, it was this Dr. Wong. There was a student actually doing the inspection, but he was prepared to do it and claims experience and decided not to because he said that it was he was concerned about perforation at that point and wanted to allow a chance for other treatment options.
Yeah. Before I had any treatments, I was told by uh, Dr. Bill. Remember our good buddy Bill up in Buffalo?
Yep.
Buffalo Will, Rick. He said, "Oh, don't worry about it. It'll go away by itself." And I guess it did for him. But I didn't do anything for 2 years, and it never went away by itself. So, I
Well,
had to have it treated. Yeah.
it was alarming to all of a sudden be throwing blood.
Yeah. Yeah. Unfortunately, it's pretty common. I'm going to ask if anyone else has dealt with significant radiation proctitis issues, and if they have, if they'd like to speak up, but it is relatively common. And there are other treatments that treat, some people use a hyperbaric chamber to treat this, and they've had some success. But there are side effects with a hyperbaric chamber as well. Anybody else? Anyone else had radiation proctitis that's been troublesome?
Yeah, Rick, this is Bill. If you remember, I had it also during the radiation treatment, to the point where he was asking me if I wanted to stop radiation. But at that point, I had like 3 or 4 sessions left, so I said just keep going. But yeah, and then one thing my doctor prescribed right away was shoot. Lynn, I know you and I talked about this too, but the word just went straight out of my head right when I was about to say it. This is the suppositories was
The sucralfate or the
hydrocortisone, right?
oh yeah, the steroid, right?
Yeah, hydrocortisone suppositories, which seemed to help me a little bit. And I did have one session of the laser treatment, but eventually mine cleared up. I have intermittent hemorrhoid problems where I'll have a pretty good bleeding after a bowel movement. But it doesn't last. I mean, it'd be like I'll have it for a day and then I won't have it for another, month or two or so.
Okay. Do you use anything like Preparation H or some sort of topical?
No, not anymore.
Okay.
No. But the suppositories seem to help a bit.
Okay.
They're not pleasant, but
all right. Thank you, Rick. The last thing
Hold
is.
on. Hold on a minute. Dr. Jeff, did you want to say something on this issue?
Yeah, Richard, what is your hematocrit now?
I don't know. I don't know. I'm sorry.
I can tell you that blood in the stool and blood in the toilet is often dramatic in appearance, but you're not losing that much blood. So it can look terrible, but in terms of dropping your blood count, it really doesn't. So find out, if you could, what your last hematocrit is.
It was slightly low, and it's been slightly low for a long time. And yes, I realize that the blood is very dramatic, but it doesn't take a lot of blood to be dramatic.
Right. And do you have internal hemorrhoids or external hemorrhoids?
Yes, I've got both.
You have both. So did you discuss with them about banding the hemorrhoids?
No.
There's a term. Yeah, ask them. It's simple. Ask them if they would consider banding your hemorrhoids. It's like putting a rubber band around it and choking it, and it kind of dries up and you won't bleed anymore.
Okay, it's like castrating a horse. Okay. I will ask
So
that question.
yeah, and you know the other issue that occurs to me, and I don't know, maybe General Joe has thoughts on this too, is that if you are going to get that argon treatment, is the military hospital the right place to get it?
Okay.
You know, I think you've really got to dig down and decide. I mean, I think the military hospitals are great for some things, but for other things, they just don't have the docs who have the experience. You know, there are no genitourinary medical oncologists at the military hospital at all, which is a concern. So I don't know if there's anybody, if there are any vets on this call who have 2 cents they want to put in on this issue or not.
Yes, Rick, I agree with your general statement. I don't know specifically about hemorrhoids and blood out of the rectum, but and how good Walter Reed is with that. But generally, Walter Reed doctors move around a lot. They get deployed a lot, and so you don't have a consistency there that you get in the civilian world. So I would certainly try to get a second opinion from the civilian world.
Okay. All right. Thank you. Uh, uh, oh, the last thing is that um, I expect to be completing my ADT in June, which will be 20 months following external beam and high dose brachytherapy.
Okay. Okay. So, you know, I think our position is anything over 18 months is probably good. And from what we've seen, if you can hang on a little more, it might be better for you. But if you're ready to go, you know, again, a second opinion on that from a good GU medical oncologist probably is worthwhile.
Okay.
And ask if, you know, would they keep you on longer or would they not keep you on longer? And I would check rather than going on the basis of the radonc at Fort Belvoir.
Okay. Well, also looking at the paper in the JAMA Oncology from 22, interplay between duration of androgen deprivation therapy and external beam radiotherapy with or without brachytherapy boost for optimal treatment of high risk prostate cancer. And the conclusion of this paper was that 18 months appears to be sufficient.
The problem is that there are multiple papers, and some say 18 and some say 24, and one came out recently that said 36. So that's why I just said to you 18 as a minimum.
All right, what would you recommend?
I wouldn't. I'm not a doc. I'm not going to make recommendations.
Okay.
I did 28 months, and it worked for me. But you know, and other people may have other opinions. But I wouldn't do less than 18. So, but I did 28 because at that time there were papers that said 36 is better than 12 and 28 is better than 4. And so, you know, it really depends. But I think what you want is an opinion from a real solid doc. And I would say this might be one of those situations where it's probably worth your while getting an opinion outside of the military and the veterans hospitals. Do you have TRICARE?
Yes.
So you can go anywhere.
Given that I'm based in Washington, who or where would you recommend?
Oh boy, probably Dr. Paller at Channing Paller, Paller, Channing Paller at Sibley. And the other person to talk to, although he's not a GU med-onc, but we have a lot of respect for him and he has the experience, and maybe you see both of them since you have TRICARE, is Sean Collins at Georgetown.
Okay.
And I think, get a consensus from Dr. Paller and a consensus from Dr. Paller and Dr. Collins, and then make your decision.
Got it. Okay. Thank you very much.
That's a pleasure. Okay, Mr. Latimer, you're back. We didn't forget you.
Yes, I'm back. I don't know what happened. I just lost my internet. Just went down. You all disappeared. So I think I'll back up a step. A couple months ago, you all recommend I go see Dr. E in Houston, which I've done, and she ran me through every test, basically every test that she could think of, the scans, the genetic testing, blood tests, and finally had a follow-up visit with her, a virtual visit with her a week ago. And this was a virtual visit, and she spent a lot of time with us. She was, as opposed to the first visit where she seemed rushed, this time she was not rushed at all. She spent quite a bit of time with us. And so the regular scans were negative. The PSMA PET showed a few lymph nodes and mostly in my abdomen. No bone, no organs. And my PSA continues to go up. It's up to 19 now. But she honed in on, this is what I wanted to talk about. She honed in on the somatic test that she'd had done at
Tempus.
Tempus, sorry. My mind, I just did one of those blanks. She honed in on the blood tumor mutation burden. And it came back as 8.6. And she said that is quite high, and that she thinks I'm a good candidate for Keytruda. But she said, you're an unusual case, and I would like to, unscientifically say, I would like to supercharge it somehow, and I think maybe we could radiate a spot or two in addition to doing the Keytruda, and the two of them together might work better for you. So she's referred me back to here in Florida. I have it done here since I don't live in Houston, and I'm working with Belusic now to get that. Well, first of all, I haven't had an appointment with him yet. We're going to see him soon. Whether he's on board with this or not, I don't know. I also see Dr. Scholl's tomorrow virtually and get his take on it. But I didn't have a chance to really understand, to talk to her about what this blood tumor mutation burden really means, and how it relates to microsatellite instability, which the same test said I was negative for.
Right.
So I don't know if anybody has any comment on what that means and how that works. And
right. So a couple of things. The first thing, just because it's topical, is that you did have some AR mutations. And
I did have one, yes.
you might want to make sure that that AR mutation, see if that AR mutation is covered by the same trial that Dr. Bob was talking about, which is the ARV-766 trial. So I don't know what I don't know what the mutations are. I wonder if I have ARV-766 bookmarked. But you know, again, with a difficult disease like is yours and a troublesome one, if it is covered, then it's definitely worth. Yeah, I do have the trial bookmarked. It's definitely worth having that discussion with Dr. E, especially since
That's, yeah, that didn't come up in our meeting, but yeah, for sure. I'm trying to look back on that test now to see what, and I lost it because I had to reboot my computer, but
okay,
to
well,
see exactly what that one was.
I mean, I don't think that we're going to, when I'm not trying to resolve this on the telephone, but clearly, as Bob just told us, there are 4 mutations that they are honing in on. And the question is yours one of those mutations, and are you a candidate for that trial? Let me see, where are they running that trial?
Well, maybe Dr. Bob and I should chat about
Yep.
that. And I will go back and look and see exactly which one it is that came up most recently on the Tempest test.
Yeah, and if you send it to me, I can send it to our peeps at Venus, and we can ask them.
Okay. Well, I certainly can. I'll pull that report and email it to you.
Okay. Now, the MSI high is an independent measure to the tumor burden. And I know that he likes to try people on Keytruda plus radiation. She thinks that there is a what's the word?
Some kind of synergy.
Abscopal effect. Abscopal effect.
What's that? What's that? How you spell that? I've been trying to figure out what that word was. I forgot that word. Abscopal?
ABSCOPAL. Abscopal effect.
ABSC.
OPAL.
Abscopal effect. Okay.
So she feels that radiation creates an abscopal effect for Keytruda, because we've heard her say that before. So I'm not surprised. But normally the cutoff is 8 or higher, which is why. So 8 is not super high. And like 20 would be very high, but 8 is high. So, the question is, you're just over the margin, so she's on a hunch that maybe you'll respond. But that's why, if you are a candidate for this trial, and I've just posted it. Hold on a minute. ARV-766. I've just posted the trial in the chat window. And so you might possibly be a candidate for that trial. The only site, but it's not yet recruiting, although that doesn't necessarily mean much, but the only site is in Florida, is at Lake Mary, wherever that is.
That's near Orlando.
Oh, okay. Well,
somewhere near Orlando.
That's the only place they show it. They show it recruiting in New Orleans, and they show it recruiting in Texas, but not in Houston. So, but like I say, I can drill down on that a little bit. But the problem with this phase 2 on this one is that it requires weekly visits. So if it's not convenient, it might not
Well,
work for you.
Lake Mary's probably a 3-4 hour drive from where I am.
Yeah, which is a schlep.
Which is still better than a 2-hour plane ride to Houston.
Yeah, Myrtle Beach. It's in Myrtle Beach. I'm looking to see if there's anywhere else down south. So anyway, but it's just a thought, and it may be the same issue, like with Bob, and if you have these mutations. So I think I definitely put it on the page. You were going to move on to something else, Al.
Oh, well, I wanted to talk about what this. So you brought up one point is that Dr. E likes to do these combination things, and try and shoot for the abscopal effect. Abscopal effect. Okay. So has anyone in our group done that?
Somebody did it, and I can't remember who it was, but somebody has done it. Peter, you have your hand up, so I'll see if I can find who it was whilst you're talking, because I'm trying to keep a lot of balls up in the air today.
Okay, Al, you and I have talked a number of times. I just want to give you a heads up here because you've got a couple of things that kind of line up with me. I did a year of Keytruda, and one of my side effects was what's called immunocolitis. I mean, I had intestinal issues as a side effect, and it carried on for 7 months after I stopped Keytruda. And Dr. Schultz recently, you might have been off there when I just mentioned it a little while ago, an hour ago, but Dr. Schultz recommended hitting my abdominal region where my Mets are with radiation, and set up an appointment with UCLA for me. And Dr. Steinberg, the head of radiation there at UCLA, said, no way. If you've got intestinal things going on, we are not going to do radiation in your abdominal area. It can really fuck it up. He didn't use that term. I'm using it. I did not want to make it worse. I mean, I'm still dealing with it. So that combination of Keytruda and radiation to your abdominal area, I just give you a heads up to research this and think about it carefully, and ask Dr. E if she's had experience with radiation to the abdominal area with Keytruda, because it can set up a perfect storm. So I would I'm not saying, I mean, you're different than me. I'm an odd duck, but be careful and do your research and tread carefully on this.
I know we've talked before, and I'm well aware of the issues you've had with it. And Dr. E is quite quick to poo-poo all that and say that it's not that bad. We can control the side effects. But I'm definitely going. I haven't made any decisions yet on what to do. I'm just trying to,
Okay, just saying. I'm not telling you. I'm certainly not telling. I'm just
so,
telling you what my experience was and is and ongoing.
So the Keytruda caused the problems in your intestines, or you already had them?
Keytruda can really mess around with your immune system in different ways. Can mess. It chopped my liver enzymes way up. It messed around with my thyroid at one point. And the last thing it did was really screw around with my intestinal, my GI tract, and that lasted for a long time. But it's still going on a little bit.
So you're doing better now?
I'm doing better. Yes, I'm doing better now, but I got to be careful. I mean, I mean, on the cancer level, it seemed to work wonders. Although things are creeping back a little bit now, but still, it was a miracle from my standpoint. I'm glad I went through it. But I mean, with anything, any drug, these are powerful drugs we're dealing with, and there are side effects. There's no get out of jail free card on this ride, as you know.
Well, that's my that's kind of my issue right now. I haven't had a treatment since the beginning of December, and I'm feeling a whole lot better than I have in quite a while. And
I'm at the end of July. I'm 8 months with nothing, and I'm really glad for it. But I still have some side effects.
So, and I'm not as young as I used to be either. So
Amen.
anyway.
Amen.
Anyway, I'm still here. I don't have a whole lot of disease after 29 years of this. So I'm feeling very lucky overall. Just a question of what to do next and when.
Yeah.
So, okay, Rick. Well, I'll send you that Tempest report, and you can see exactly what it said, um, and I'll look into that trial and see and talk to Dr. E about it, see where it goes. Appreciate the tip.
It's not me, it's Dr. Bob. I wasn't even going to start talking about our Venus's trials until later in the year when we had a firm date set up with them, but the trials are on our radar, and they've at GU ASCO they asked if we would be willing to publicize their trials and help them out, and I said because we like them.
Dr. Bob has left the meeting tonight, I guess.
He has, but his email, I think it's Dr. Bob at AnCan.org. Let me just verify that for you. Dr. Bob.
Hey, Peter, what was your TMB? Do you remember?
It was in the high range. Yeah.
Yeah, because I always thought
Not super high, but high.
TMB high was at least 10, between 10 and 20, if not higher.
No,
I'd never
it's
heard
over. It's over 8, Len.
Yeah, I guess they
It's
changed
over 8. Yeah. The TMB over 8 warrants concern, but 8's sort of the margin. 8's the cutoff. Peter, let me see if I have it. And it's Dr. Dr. period Bob. Dr. period Bob.
Bob at AnCan.org.
Yeah. And I'm just seeing, Peter, if I have your TMB any easy to see.
I should have it here someplace too.
I know. There's a lot of notes. I got a lot of notes for you, Peter.
10 years worth.
Yeah. 10 years worth, indeed. I'm just Pembro, Keytruda 1.79. I don't see it. I don't see it.
I have from Foundation Medicine. I have intermediate at 14.
14, right?
They're calling it intermediate.
That was in 18, January of 18.
It's not even high.
Well, but it's not Len, that's not the criteria. The criteria is that the Keytruda are the Keytruda approvals, and the Keytruda approvals are for a tumor mutation burden of 8 or higher.
Where's that coming from, Rick?
I can't remember, but check it out.
Now, I'm just thinking because, as Peter said, it's a powerful drug, potentially serious side effects, and if you're borderline TMB high, I think it's risky.
Well,
Personally.
it's borderline TMB. It's borderline TMB eligible. Now,
Yeah, right.
is it risky? I don't know. I mean, we're not here to give medical advice. But
Right. I mean, I'm just
the
saying,
point
like
is that,
we often say, if it were me, that's what I
well,
mean.
if it were you, you wouldn't do it.
I wouldn't do
If
it.
it
Yeah.
were me, I don't know what I would do, but Keytruda is a drug that can be prescribed if your TMB is 8 or higher. Now, that we can tell you because she can get it approved. I mean, the insurance will pay for it at 8 or higher. You know, need to take a look at some of these basket approvals on um, pembrolizumab, because these are all related to basket approvals. These were not necessarily approvals that were done in prostate cancer, because that's the way the Keytruda has largely gotten approved. I mean, some specifics, but by and large, it's what they call a basket approval. So if you're MSI high, or if you are tumor mutation burden, Thomas, tumor mutation burden. So if your TMB is above 8, then I think you'll find that it's approved. Now there's a whole nother decision. Are you the right person? And do you want to take a chance at 8? And I think that's a very fair point that Len makes, and a very good point that Peter makes. And, and it's a discussion to have with Dr. Elaney, and to compare it against other treatments. Go ahead, Peter.
Yeah, I think I mentioned a few weeks ago that Schultz had me do another blood liquid biopsy with Garden 360 last month, and that one the TMB came back at a 4.73. So, I don't know. I question the Garden is accurate, but maybe my tumor mutational burden dropped by a third. I have no idea.
Well, yeah, but Peter, when was it? When were you measured at 14?
2018. So
Okay.
6 years later, all of a sudden.
So 6 years later, it's like saying, well, my PSA when I was diagnosed was whatever it was, 60, but today it's 0.5. You had treatment.
Could be. I don't know much about these things. I don't know much about this.
Well, you know enough,
Peter.
But Peter, it's not beyond you. You know enough to know that treatment affects your responses.
Of course.
And treatment changes. Treatment changes your PSA.
Yeah.
So, I think that what we've got to do is we've got to look at these tests and we can't just say, well, I'm now at 4.0, but I was at 14. Well, 6 years apart with a whole bunch of treatment in between, including a lot of immunotherapy.
Could be.
So
could be.
that's what it's supposed to do.
Yeah, I'm not complaining. I'm just saying some of this stuff gets a little bit beyond me. I don't think I was very good at biology in high school.
Well, you don't have to be good at biology to know that if you have a treatment and it improves your overall condition, your numbers are going to get better.
I guess, yeah. I hope so.
I guess so. We hope so. That's why we do the treatments, I think.
I think, yes. Well, good luck. Good luck to you, Al.
Yeah.
Thank you. I'll keep you posted. So Peter, you were talking about Guardant. My TMB, I had a Guardant. My most recent Guardant one was in July of 23. My TMB then was, according to Garden, was 23.
Okay, good.
And now
Who ordered it? Schultz or Dr. E?
it was ordered by the University of Miami.
Okay. I don't think Dr. E is not a fan of Gardant, I don't think.
I know she's not, and she saw the Garden report, and she really wanted to do another one.
Okay.
So anyway, I don't know how good these tests really are. I mean, that's a huge difference between the two of them. And the only thing in between those two was I had four more treatments of the of Pluvicto.
Wow.
So
Okay.
was that test accurate then? I have no idea.
Well, we have concerns about the garden test, so that's all I can say.
Yeah. Well, Dr. E said that the Garden was okay as far as it went, but it doesn't test enough things. That's why she liked, well, at least that's what she told me. That's why she liked Tempest better. But anyway,
Okay.
thank you very much.
That's a pleasure. And I think we're about ready to close down before I'm the only one left on here, which will be very soon. So, because they're dropping like flies. All right, next week, Tuesday, 6 o'clock. Peter's in the hot seat, and I guess we'll all be back. Well, some of us will. Good night, everybody.
All right.
Good night.
Thank you.
Thank you.
Thank you.
Good night. Thank you again, Rick. Take care.
Thanks, Rick.